Coming up on today's episode of The Health Review.
If the next 50 years you are going to be living in a menopausal state, you want to be living well. It is effectively a stage of a woman's life where everything changes. Perimenopause is around sort of 7 to 10 years of a woman's life before her periods get up and walk out the door.
This could, for many women, start
In
mid
their
to late 30s.
Absolutely. Is it something that I believe most physicians in the UK recognise in a woman's late 30s? No, I don't. The amount of women that I see, both in my NHS and private practice, who come to me, and they come to me 5-6 years later, sometimes even later than that, with severe symptoms. They've quit their jobs. They've had relationship breakdowns. They've lost confidence. They've tried everything. They've seen 3 different specialists, but no one's identified menopause. I think we're not picking up these women early enough.
Before we jump into the conversation, I just really quickly wanted to say that this truly is an episode for everyone. I know myself, I've been guilty in the past of a few years ago seeing something about the menopause and maybe not paying as much attention to it as I should have. But now, there's just so much evidence to suggest that what we do in our 20s and 30s as women can really affect how we experience the menopause. And of course, for all the guys out there, it's time to support women going through the menopause. Listen up, pay attention, and I've got one of my favorite people in the world joining me for this conversation, Dr. Reem Alshaikh, back by popular demand, I must say.
Hello.
Hello, thank you for coming on. This is your area of expertise. You are a GP in the UK, working for the NHS for many years, but you also have your clinic, the Women's Wellness Clinic. So you specialise in this topic. You're educating the world on TikTok at Dr. Reem, where I've learned so much through your content about the menopause. So it only felt right to have you here today to go through this. We know around 85% of women, majority of women, will experience some kind of symptoms, which we can go through in a minute about what they are. 50% of women roughly will experience some kind of osteoporosis related fracture, which is really quite terrifying when you hear that number. And also more than 50% of menopausal women report experiencing anxiety throughout that process. So I think those figures just really highlight the importance of kind of awareness and linking it and research. So I really want to get into your views on all of this. But first, can you just explain in simple terms, what is the menopause?
The menopause is a single day in a woman's life, just one day, that marks the end of her ability to reproduce naturally. And it's a farewell to her menstrual cycles. So we define the menopause as 12 months from the last time you menstruated, assuming that's natural, no hormones kind of at play. So when a woman has gone 12 months with no periods, she is stamped menopausal. And anything that happens to her after that is classed as post-menopause. So the menopause itself as a word, as an entity, is just one day. It's just one day in a woman's life, yet so much is happening to women. And what I would say with your statistics is 100% of women or persons with an ovarian system are going to go through the menopause. That is the headline. It is going to happen to every woman. And so we really need to understand what that actually means. Because the one day when you go, okay, a year ago, I had my last period, now what? It's just not as straightforward and as black and white as that. And there's so much that's happening within a woman as she's entering that phase of her life. We are designed as humans to reproduce, and we are outliving what we were designed to do. And women are spending just as much of their lifespan without their estrogen hormone post-menopause as they are spending their lives with it. Yet we don't really understand it that much, if I'm really honest. We don't necessarily study it as much as we should. We don't cater medicine and disease management to a woman with and without her hormones. So I think we need to kind of get into what does it actually mean, what's happening to our hormones at that stage. But effectively, it's just a day. It's just one day.
And in terms of hormones, we hear a lot about estrogen. Are there other hormones that fluctuate and change throughout that process?
Absolutely. So Our ovaries, our female sex organs, they produce lots of hormones. So estradiol is what we're going to be talking about. Estradiol is your estrogen. And then we also produce progesterone and testosterone and various other hormones that are really important in our menstrual cycle and in our life. What's happening in menopause is our ovaries are slowly shutting up shop. It's like a large factory that's been working for many, many years being decommissioned. So what's happening is, it's sort of not as active. The opening hours start to shorten. Sometimes you're closed on a Saturday night and very slowly they just shut up and they stop producing the hormone that we need, estradiol, our estrogen. And effectively, at some point, we just stop being able to produce an egg and ovulate. And what's happening to us in that time is we're starting to get symptoms because we're starting to feel the loss of those hormones. And there are many other hormones at play. So what I sort of in its simplistic terms, our brain has a huge effect on stimulating our ovaries to do its job. And so one thing I want every woman to understand is estrogen, our hormone, our female hormone, what makes us largely very different to men, it's really important for us. And every part of our body has an estrogen receptor in it. Our brain, our guts, our skin, I could list everything. There are estrogen receptors everywhere. So if we start thinking about the fact that our estrogen's starting to decline, then we can start understanding, okay, there's just not enough estrogen to get around to all these receptors. And if there are receptors in my brain, then my brain really needs estrogen. So when I don't have enough, my brain's going to start to act a bit funny and I'm going to start to notice it. And so it's something I want women to understand, even young women, because every woman, as you said, 20, 30 plus, you're going to go through your menopause. And you do need to understand why that's important to understand and what it is about that's, something that's really in your hands. You can't change the fact that Mother Nature is telling you that you're getting older, but you can embrace that change and make sure you are ready for it and are optimal with your health and your habits and your mindset so that when you're at that point, you can get through it. But remember, we're not getting through one thing in one day. We're basically saying we reach midlife, and then from midlife onwards, you might live to 100. The next phase of your life is going to be different. So how do we ensure that you're healthy, well, and joyful, active? How do I ensure that for the next kind of 50?
And I think now there's, we can go through in a minute some of the symptoms that women experience. But when you say that we have estrogen receptors all over our body, that kind of makes sense as to why there are just so many symptoms that women are now able, there's more of a platform. So people are talking about really specific things, which I think, like if you go back 20 years and earlier, were just never linked to the menopause. Is it true that it's a whole body change?
It's absolutely a whole body change. And I think traditionally people have just assumed that when you go through menopause, you get hot flushes, you get hot and sweaty, you get night sweats. You might, as an old lady, become a little old lady. You might start to shrink. That's osteoporosis untreated. And we accept that culturally. Women get hot and they get a bit emotional and they kind of cry a bit and then they start to shrink. And I think society goes, yeah, that's what happens. That's just what happens to women. Granny used to be tall and now Granny's really small. And I think every culture can identify with that as being something that is socially kind of just accepted. With regards to going through the menopause and it being a whole body effect, menopause is not a disease. It is effectively a stage of a woman's life where everything changes. And we've always known that women to some extent have been affected head to toe, but we just didn't validate it. We didn't categorize the symptoms. So if you now look in 2025 at the category of symptoms that are completely identified, proven, accepted, there's at least 70 plus different symptoms that are reported and understood to some extent when a woman goes through her menopause. If I turn back my career 15 years, I literally thought and was taught menopause was hot flushes, a woman's going to basically stop bleeding and eventually she'll just adapt and be fine. And so I have observed women over the years and observed their symptoms and observed what menopause is doing to them. And, to some extent now, I've got way more options and tools and a deeper understanding of what I can do to help women get through the symptoms of menopause, but also more importantly, or as importantly, understand what is happening to her, what her choices are when it comes to menopausal supportive treatments and why she might choose them. So yes, it's top to toe. You can present with frozen shoulder.
What is frozen shoulder?
Basically, frozen shoulder is when the capsule around the shoulder joint, effectively, a simplistic term, just becomes really sticky and inflamed and basically starts to cause issues with mobility. It can cause severe pain and your shoulder can become stuck. We see frozen shoulder happen out of the blue. Women will come and go, I don't know what's happened. There's been no trauma. I haven't done anything. This has never happened to me before. This woman will be often in her late 40s, early 50s. She will end up in front of a physiotherapist. She might even end up in front of an orthopedic surgeon in the UK or a rheumatologist, a joint specialist. And in the end, they'll inject her with steroids. They'll try and make it better and they'll say, well, it will just get a bit better with time. It can take 1 to 2 years to get better. But what's really interesting is we know that for whatever reason, shoulder joints particularly susceptible to the loss of estrogen. So again, like everything, remember, it's covered in estrogen receptors. And if you don't have enough estrogen knocking around, it can present as a symptom. And so there are so many women who you look back and I'll go, oh my God, that frozen shoulder was probably the presentation of her menopause. That was the beginning of her estrogen changes, except nobody is having that conversation with her. And I think we have come a long way around discussions around menopause and understanding that women are going through it. But I think in our current medical setting, I think specialties are still not recognizing the symptoms of menopause. So I think to put this, I want to talk more about symptoms, but to put this more into perspective, I think what's quite important to demarcate is the terms I'm going to use as we have this chat. So menopause, as I said, is one day. Periods have gone. They went away a year ago. Bye-bye periods. So postmenopause is everything after that. You've had 12 months of nothing. Everything after that, you're in postmenopause. Perimenopause is around sort of 7 to 10 years of a woman's life before her periods get up and walk out the door.
So this could for many women start
in
mid
their
to late
late
30s.
Absolutely. Is it something that I believe most physicians in the UK recognise in a woman's late 30s? No, I don't. The amount of women that I see, both in my NHS and private practice, who come to me, and they come to me 5-6 years later, sometimes even later than that, with severe symptoms. They've quit their jobs. They've had relationship breakdowns. They've lost confidence. They've tried everything. They've seen 3 different specialists, but no one's identified menopause. I think we're not picking up these women early enough. We're not having the conversation. I think when we were, training in med school, when I was a medical student, 20 years ago, was obstetrics and gynecology training. We learned all about having babies. I can tell you everything there was to know about how you deliver a baby and what you do and why that's important in a pregnant woman. And you basically had a lecture one day that mentioned menopause. And and by the way, a woman's cycle ends. That's called menopause at the end.
That's so depressing.
I know.
Oh, it makes me mad.
And it is changing. But you have to remember that there's a whole school of physicians in the UK and the world who have had no training, who sort of go, okay, well, where have we come? Where we've come is that people understand that women maybe have some hormonal choices. Do I really believe that people understand those choices? No, including physicians. So it's a really exciting time, I think, for women, but it's still really difficult to navigate because you're to some extent at the mercy of the person you're talking to and whether they pick it up. So a woman, if the average age of menopause in the UK, just so you know, the average age that your periods are going to just leave is around 51 years old. Now, anywhere between about 45 and 55 is a normal range. So if you're the 45-year-old woman who's going to stop having periods age 45, then you are going to present with symptoms in your mid-30s. And often those women are just shooed away.
What are those symptoms then?
So you can have musculoskeletal.
This is perimenopause.
So perimenopause and menopause, meaning your estrogen levels are starting to fluctuate in perimenopause. So what's happening in perimenopause? Let me just describe the hormones and we'll talk about the symptoms. So if you imagine a hormone cycle as much like a really let's think about wallpaper in a granny's house. So if you imagine a repeating pattern on the wall. So you've got a beautiful repeating pattern in your wallpaper. That is roughly what a woman's menstrual cycle on average, without problems, is going to look like month on month. It's perfect. It just repeats, it repeats, it repeats. In perimenopause, so remember, this is the 7 to 10 years before your periods actually stop. What's happening to that hormone cycle is it becomes completely chaotic. So now just imagine I've given a 3-year-old a big fat crayon and a piece of paper, and I've asked them to draw a picture. If you've ever seen that happen, what they do is they scribble. It's just like random. It's everywhere. And that's what your hormone cycle looks like in perimenopause. It's completely erratic. There's no pattern to it. 1 minute your hormone is up, your estrogen is sky high. The next minute it's rock bottom. You feel great, then you're crying. You feel completely able to manage life, then you suddenly feel that you can't. You might feel achy. You might get vaginal symptoms. The genitourinary syndrome of menopause is effectively me going, do you know what? All of the tissues around your bladder, your vagina, and everything in between start to suffer because you lose estrogen. That can present with recurrent urinary tract infections. You might have painful sex. You might suddenly get vaginal infections that you've never had before. So if you're a late 30-year-old woman turning up with something called bacterial vaginosis or thrush, then you're going to be told, oh, it's because you're young, your sex, you have to get cleaner, wash better, do this, do that. But it might not get recognized that this is GSM. It might not get recognized this is an early sign of your menopause, and that your hormone levels are fluctuating and your environment down below is changing. And actually the treatment for that, just so you know, is local vaginal estrogen, not recurrent antibiotics and constant antifungal medication. So, it's important that we start to really understand that a multitude of symptoms can happen. Now, other common things that women talk about are not being able to focus and function.
In the perimenopause? In
the perimenopause, suddenly you're walking into a room and you're thinking, hey, Emily, can you pass me that thing? It's green. It's got a handle. The mug. It's like you'll look at something and you won't know how to describe it. Or I'm sure everyone can relate to this. You walk into the room and think, why am I here?
Yeah.
Why did I walk in here? Or worse, you are a high-level exec in a boardroom and you're suddenly giving a presentation to your client and you can't remember their name. You're serving someone in a supermarket and they ask you for something and you give them the wrong product. And you look crazy. You're not crazy, but your brain is foggy. And if you can imagine that happening to you as a woman, you'll start to think you're dementing, you'll panic, you'll go, what's happening to my brain? I can't cope. I feel so embarrassed. Throw in a massive hot flush where all of a sudden, you're in front of a crowd of people and you're talking to them about something quite important and suddenly you get red hot and sweaty and actually steam is coming out of your head.
Because that's true, right?
It's true.
There are videos on time. I mean, I've seen a video on TikTok of a woman in a cold climate with steam.
It's absolutely true. And it's varying in severity from one woman to another. And there's lots of differences as to why some women get more symptoms or more severe symptoms.
With the hot flushes, can I ask quickly, is it something that you can experience in the perimenopause stage quite early on? Because I think we all associate that with women who are late 40s, early 50s and beyond, so not younger.
Okay. So the answer is yes. You can get those symptoms at any stage of perimenopause. We do see what we call in medicine vasomotor symptoms. All that means, ladies, is just feeling hot. And just to give you nomenclature, the Americans say hot flashes. In the UK, we say hot flushes or night sweats. And night sweats you are literally dripping wet. You throw your covers off and then you're freezing. You throw them back on. You wake up your partner. Everyone's in a bad mood in the morning. Big problem. And so, hot flushes, vasomotor symptoms can be very debilitating. And they do, interestingly, tend to be deeper set in once your estrogen levels have really, really rock bottomed.
Right.
So you're right, we do see it later, but you can see it at any time. The way I think about estrogen, just to get everyone's heads around what's actually happening to them, because I think what's tricky in perimenopause is in perimenopause, you are often still ovulating. You are still having periods. Now, this is assuming you're not on a contraceptive pill, you don't have a contraceptive device in situ, that there's nothing else interfering. So let's just say I've got a natural woman, au naturel, not using any external hormones that have been prescribed. So she is going to be, remember, like the kid with a crayon, her hormones are everywhere. But what is absolutely happening in that period of chaos is overall the trend of her estrogen is going down slowly.
Right.
So if you imagine that every woman is a cup and they're full of estrogen, the cup is full to the brim. When you're 20 years old, Emily, your cup is full. So if ever I give you, for example, a contraceptive pill, let's say I give you a combined oral contraceptive, what I'm doing to you in that moment is I'm pouring more hormone on already a full cup, and I'm overflowing your cup. The type of estrogen in the combined contraceptive pills is different to the estradiol, the more naturally matched estrogen that we give in hormone replacement therapy. And so as a woman is going through her menstrual life, her cup of estrogen is slowly going down. So now let's just say you're 30 or you're 35. Your cup's no longer full to the brim naturally, but it's starting to go down. So if you look at the cup, it's not half full, maybe it's 2/3 full. So you've lost estrogen, but you still have enough estrogen to ovulate. And that level continues to decline. So you can be becoming estrogen deficient, but still ovulate. So I think what blows women's minds is they'll come to me in perimenopause in their late 30s, early 40s, and they'll be having periods. So they will go, well, it can't be perimenopause because I thought menopausal symptoms means my periods have to have stopped. But they don't have to have stopped. Menopause, remember, is just one day. That's when they've officially gone away forever. But the symptoms of that change happen in that decade before. And so what everyone needs to try and start getting their head around is as their levels are starting to fluctuate and go down, but remember they can go up and down like the crayon, but overall, over time, they're slowly dropping and they're dropping until there is no more estrogen left. And often if you show up to someone like me, so I'm a British Menopause Society specialist, if you show up to me and you are in your post-menopause and you lost your periods 3-4 years ago, you'll just be in a completely different place symptom-wise than a woman who I'm meeting earlier on in her journey.
I'm curious. So we all experience the stage after ovulation where your estrogen declines. Is that feeling relatable? So, I mean, a lot of people get PMS symptoms. You know, you don't feel quite yourself. You can feel on edge, anxious, sad. Is that what sort of perimenopause stage
can
look
feel
like?
and actually you said a brilliant statistic at the start of the show. You said, you know, anxiety is a really, really common presenting symptom. And imagine someone is just playing havoc with your hormones. You know, you're a little pot and someone is shaking you up and down all the time. You're going to feel completely chaotic and out of control. And interestingly, we do see an increase in women presenting with depression symptoms in perimenopause and menopause. Symptoms, or women on the ADHD spectrum, tend to get a sort of volume up on the symptoms that they've kind of lived with their whole life. And then suddenly they're like, why can't I manage things in the same way? Nothing about me has changed, has it? But it's because their hormones are changing that suddenly their brain doesn't work properly. And it's really interesting because if you walk into any GP practice, I would say in the UK at the moment, and you're a woman in perimenopause, remember it's 10 years before your period stops, so you're basically 30 to 40, and you basically go in with anxiety symptoms, you are way more likely to leave that room, phone call, online consult with an antidepressant and maybe a conversation about, you know, chill out, go be mindful, go do some therapy, whatever you might need to do. And don't get me wrong, you might need to do that. But you're way more likely to leave with a drug which treats anxiety and depression than you are to have a conversation about, could this be perimenopause? Are there other options for you and the symptom you're presenting with? And the amount of women who I see and they've been on antidepressants and they eventually get to me and we go, wow, okay, I can see why that was given to you. But actually, really, at the moment you were given that, you should have been having a conversation about what your other options were.
How do you know? So for sure, is there a blood test which you can do, which can signal, right, okay, you are definitely going through the perimenopause and this is what you need?
So just imagine for a minute the repeating pattern. So remember the wallpaper. We've all seen wallpaper that repeats, beautiful wallpaper that looks lovely, and every few centimeters the pattern repeats. So if you are someone with a repeating pattern, I can predict at what point in that pattern to do a blood test and see the hormone levels that I'm expecting to see. But remember what I said about the kid with the crayon. If the kid with the crayon is completely random, up and down, left, right and center and all around, tell me how a blood test is going to help me or you know where you are. It's not. So what I want women to understand is when they come and tell me, oh, but my doctor 5 years ago did a blood test and it was fine, I'll go, oh my God, but it wasn't fine because 5 years ago you were perimenopausal. And it just so happens that the day they did that blood test, they just caught your hormones in a point that looked all right. Had they done it 20 minutes later, 1 day later, 3 hours later, you would have looked menopausal. So what I would say is blood tests are hugely important if a woman is under the age of 40, because premature ovarian insufficiency, that's what we call it in the UK, POI, is when a woman has gone through a much earlier than expected menopause, and that can have long-term, quite severe consequences, not only on her mentally, physically, on her bone health. So that woman needs to know. So, it's really sad, and some women do go into their menopause naturally very early, or they've been thrown in it because of surgery, maybe for cancer, maybe for something else. And, we need to know what's going on if they're under the age of 40. Between 40 and 45, there is actually guidance around doing hormones to understand where a woman is. But if I'm perfectly honest, I don't think that is that useful,
right?
Because that woman is perimenopausal and those hormone levels do not dictate how she feels. So, for example, if you're 42 and I do your hormone levels and they look normal, and what I mean is, they tell me what I know is that, and what I know is that you ovulate.
Yep.
They don't tell me about how you feel. They don't tell me about whether you're getting hot flushes. They don't tell me about whether your vagina is dry and sore. They don't tell me about whether you've got brain fog symptoms, achiness, tinnitus, which is ringing in the ears, palpitations, really fast heart rate, anxiety. It doesn't tell me any of that. And so they're not particularly useful. So if you as women are being told, let's do some bloods and see where you are, and you are in what you consider to be a perimenopausal time of your life, I would push back and say, no, I don't think that's actually going to be helpful, because how is that going to tell you whether or not the symptoms I'm having make sense? It's tricky, because I think many doctors still do bloods totally without reason, and they don't know how to interpret them.
Yeah.
And women are getting, to some extent, just gaslighted and told you're fine when they're not. And they need to have conversations about what this means, what's happening to their body, and what their options are.
In terms of the AMH hormone, so that can be an indication on your ovarian reserve. A lot of people look at it when they are thinking about fertility, going through fertility treatment. It can tell you whether you might be able to have a child, whether you've got enough eggs. So if your AMH is higher or a good amount for your age, does that mean you might experience perimenopause, menopause slightly later? Can that be an indication of when you might experience the menopause?
So the way I would look at understanding menopause and when you might experience it, when we're in utero, so when we're in our mummy's tummies and we're in their uteruses and we're little babies and we're developing, in that moment, you and me as little girls, little baby girls, we've got the maximum number of eggs that we're ever going to have for our whole life when we're in our mother's stomach. When we're born, we just are shedding eggs month on, eventually, let me rephrase. So we have the eggs in the mummy's tummies, and then we're born and we're little girls, and nothing is happening to our eggs until we go through puberty.
Yeah.
We go through puberty, we get our periods, and then we're starting to see our egg volume, our egg reserve decline month on month, year on year. Basically, by the time we're 30, we have in the region of 10% of our total number of eggs left. By the time we're 40, it might drop to about 3 or 4%.
Yep.
And the quality of those eggs changes over time. If somebody has a higher egg reserve and they've gone and had an AMH blood test done, then you could assume, okay, you've got more eggs than we're expecting. So probably you might find that your menopause is a touch later. It's possible. But there are so many other factors that can influence that, and then there are other treatments that women may or may not be having. And so the reality is, there's quite a strong genetic link between when your mother went through her menopause and when you'll go through it. It's not exact, but it's strongly linked. So if your mother had a really early menopause outside of being thrown into it surgically, then you are probably going to have a more naturally early menopause as well. If your mother experienced really severe symptoms, you might, not necessarily, but you might experience similar severe symptoms. And then you have to bear in mind there are many other lifestyle factors that influence symptoms as well. So whether you're very overweight, whether you smoke, whether you drink a lot of alcohol, whether you have any other medical conditions. And then there are some ethnic variations as well. And I think what's important to when we're thinking about menopause is, I'm originally, my heritage is Arab. There's not really a word in the Arabic language to really actually define menopause. The translation is basically you can't have babies anymore. So a
Right.
woman's defined by the fact that she can't have babies anymore, but the actual, many languages don't even have a term for what is happening to women. And what's important about that is if there's no language to describe it, then culturally there may be no conversation around it. And for a lot of cultures, the minute you can no longer have babies, you have completely lost your value within society.
It's so sad.
It's so sad. And I think it's really important that we sort of empower women to understand that, remember what I said, if we're living longer, if the next 50 years you are going to be living in a menopausal state, you want to be living well. You don't want to be living in poorer health. You want to feel good. And that's where I think, the kind of conversations around what a woman's choices and options are become really important.
Sorry to interrupt. If you're enjoying today's episode, please do subscribe or give it a follow so we can keep giving you excellent content and bringing on amazing guests that hopefully you're loving on the Health Review podcast. Now back to the show. So how important is the pill throughout this process? Because I know that some people opt for topical estrogen. What is advisable?
Let's talk about menopause hormone therapy. And in the UK, we largely describe that as hormone replacement therapy, HRT. What I want women to understand, first of all, is that hormone replacement therapy is not the same as if you had a hormone deficiency. For example, you have an underactive thyroid. If you have an underactive thyroid and you're a man or a woman, you will basically be extremely unwell unless we replace it. We replace that hormone in its entirety to get you back to balance. Hormone replacement therapy is not exactly that. I'm not trying to replace exactly the hormone. I'm just trying to say if your cup is starting to empty, somewhere in that moment as the cup is emptying over those years, you're going to get quite severe symptoms. Let's talk about symptoms first. And if I just replace some of your estrogen just a bit, if I top up your cup just a bit, I'm not trying to get it to the top, I'm not trying to overflow it, I'm just giving you a bit, you often find extreme benefit with regards to symptom management. So remember, you're lacking in estrogen. All the receptors are looking for estrogen all the time. Everyone's fighting for the estrogen that's knocking around. If we just go and put a bit back into your body, you often find many symptoms resolve. So hormone replacement therapy is me giving a woman estrogen, the thing they're lacking, the thing they need. And there are many different ways I can give you that, and we'll discuss that. But what's really important to understand is if you're a woman with a womb, meaning you've never had a hysterectomy, you've never had surgery to remove it for any particular reason, or you weren't born, you weren't born without it. If you've got a womb, you have to have progesterone to protect the lining of the womb against the bad effect of estrogen. Because what we know is if I give you estrogen, the thing you need, the thing you're lacking, the thing you're deficient in, and I give it to you just on its own, what the estrogen can do is it can rain down on the lining of the womb, and it can make the lining of your womb twist and turn and change. And any cell that's constantly twisting, turning and changing can become abnormal, and abnormal can become cancer. So you have to have combined HRT. So they're the kind of real basics. Hormone replacement therapy is us saying, could we help your symptoms? Could we talk about your long-term health outcomes by talking about hormones? And estrogen, I don't want women to get confused here. Estrogen is the thing you really need.
Yeah.
But you can't just have it by itself.
Right.
If you've got a womb.
Okay.
Does that make sense? And then comes the kind of conversation around why do people want it? Why don't they want it? There's so much controversy around it, and there shouldn't be.
Well, the Women's Health Initiative, I do feel we need to discuss what happened in that catastrophic study that came out and changed the future of HRT for a good 20 years.
So the WHI was a groundbreaking study in the 90s, late 90s. What they were trying to do is they were trying to, in a really great way, prove that actually women on HRT actually had, good health outcomes. They sort of started it with this really nice intention, and it was a randomized controlled trial. So they basically had a big group of women. What's really important to understand about the WHI is that this study, it really did cause such controversy. It gave such false information at the start that generations of women didn't access hormone replacement therapy or stopped using HRT overnight. Now, when they did the study, the average age of the woman that was recruited was around 63. So what I want everyone to understand is they were giving HRT to women in their 60s and 70s who had been in their menopause for years. These women were already older. Their bodies had adapted to having no estrogen. They took anyone with a hot flush wasn't in the study because a randomized controlled trial is when you've got a treatment arm and then a blind arm. So you can't, if you gave a woman, you're not meant to know which group you're in. Am I being given a placebo drug? Am I being given the real deal?
Right.
And if you had a hot flush and you got the real deal, your flush would probably get better and then you'd know what you were being given.
Oh, okay.
So there were two arms. There was the estrogen only arm. So these women had, no wombs. And then there was the arm with estrogen and progesterone. And then they started giving out oral HRT. They were giving, we don't really use it anymore, but they gave an oral equine estrogen, meaning it comes from the urine of horses, and they gave it in combination in the combined arm with a progestogen called Provera. And again, we can talk about the different types of progesterones. And so what they found, though, is they sort of, let women go off and start this HRT. And the study was concluded quite quickly in the combined arm because about 2 years in, I think it was about 2 years in, they basically noticed that breast cancer absolute risk had slightly changed in the combined arm.
Yeah.
So this study told the world that HRT caused breast cancer. HRT does not cause breast cancer. And if that's the one misnomer I could get across today to doctors, prescribers and patients, that's what I would say. It does not cause it. What actually happens is if you looked at the study data, the risk of a woman having breast cancer was around 3 in every 1,000 women per year. 3 in 1,000 women per year were getting breast cancer. And in the treatment arm with combined HRT, that increased to 4 in 1,000. So there was one extra case per 1,000 women. And that, in a relative risk perspective, is around a 25% relative risk. So the risk of 3 in 1,000 compared to 4 in 1,000 sounds dramatic if you use relative risks. This is a mathematical statistical analysis that's used. And what happened is the media just went and told all the women in the world, if you take HRT, you've got a 25% increased risk of breast cancer. And that was not true. And then they let the other arm kind of continue, the estrogen only arm. And just so you know, in the women who were using estrogen only, their risk of breast cancer over years went down. But they didn't publish that. And then what we also know from that study is that they ended up stopping the estrogen only arm because they were concerned that women were getting more strokes. But remember what I said, these women were in their 60s and 70s. And what that study, years on, that study has been, re-looked at, reanalyzed. We understand that what was told to the world was wrong. But I cannot tell you, even today, 2025, you've got consultant gynecologists giving women wrong information. Just the other day, I had a woman come to me and say, my consultant said what you gave me was wrong because it's going to give me cancer. And I just go, oh my God, tell me how is possible? How is it possible that you're still being told the wrong information by the people who really should understand it the most? And there seems to be more and more emerging data that thinking about your hormonal choice early is important. The hormones are not just about symptoms, Emily. They're also about thinking about, do I want to benefit from this cardiovascular disease protection? Are you telling me that if I sign up to hormone replacement therapy, I'm likely to have longer term, less heart attacks and strokes? And the answer is, yeah, as long as you don't try hard, as long as you're not smoking 20 a day, and you're living a healthy life, being on estrogen is extremely protective against heart disease. It's also protective against osteoporosis because 50% of women over 50 break a bone because they've got a disease called osteoporosis. Osteoporosis is not inevitable. So women are getting it because they lose estrogen.
Yep.
Men tend to see osteoporosis when they're over the age of 70. And in women, remember what I said, 50%. So there is something about losing estrogen that increases our risks of osteoporosis, but not 100% of women are going to have these really severe, buttery, soft, breakable bones. But losing estrogen definitely massively increases your risk. So you need to be thinking about, do I want HRT because that might help prevent the risk of this, or what else can I be doing to prevent my risks?
You talk a lot on TikTok about bone health actually being linked to all sorts of other things in your body which you wouldn't know. And I think this is an important thing for the girls in their 20s and 30s strength training now it's having a moment, and thank God it is, because this is a really good way of preventing osteoporosis in the future. Are there any other things you can do? So if you are maybe a bit younger, do you need to check your calcium? Is that something that might help prevent osteoporosis in the future?
Strong, not skinny, is definitely the kind of approach. And what I mean by that is, a lot of us exercised when we were younger to be thin. And, when I was, at medical school and learning, being thin was considered to be healthy.
Yeah.
And everything was around just don't get obese. Strength training, what we understand, and there's so much good work going on around the world, so many great researchers. In the States, there's a GP called Dr. Gabrielle Lyon who's doing loads of work around muscle as an entity. Dr. Vonda Wright's an orthopedic surgeon in the States, and she talks loads around bone strength, longevity, how pounding the bone, doing resistance training, doing kind of your heavy weights is really good for bone turnover. And what we know is bone turnover is part of our metabolic health, meaning you're likely to have better management of your sugar levels if you're building bone and if you're building muscle. And that's where things like nutrition comes in, thinking about protein, being mindful of how you eat and move. So it's not that I don't want people to cardiovascularly work out. It's not that I'm saying don't go and get your heart rate going. It is really important. But strength training, resistance training, building muscle, building bone, being able to look in the mirror and go, actually, I look really strong. And strong is really important for longevity, because when we're thinking about menopause, we're at midlife. And we're thinking about the next 20, 30, 50.
Yeah.
And you want to get to your 80s and 90s and be able to get a suitcase and put it in an overhead locker really easily without thinking about it. You want to be able to kneel down and play with your grandkids and get up off the floor with no problem. And in order to get there, as a woman, you need to be considering how you're going to strengthen up. Now, hormone replacement therapy might be part of that decision. Not everybody wants HRT. Not everyone might choose it. Not everyone may feel they're allowed to have it, because you have to bear in mind around breast health, women with active breast cancer, it's not that they can't have hormone replacement therapy, but it's a lot more of a complicated, nuanced conversation with those women as to whether, because of their breast issues, HRT is right for them. I think for the younger women, what I would say is just thinking about, healthy habits. If I could turn back the clock, what would I do? I would definitely stress less about how I looked in the mirror from a thin perspective, and actually just really embrace feeling strong. And feeling strong does not mean you need to bulk up. But, I was calorie restricting. It's the worst thing you can do. And I just thought, well, if I eat less, I was doing 12-hour shifts as a doctor in hospital, I just won't eat, and I'll lose weight. And losing weight is important to me because then I look thinner. And it's a really bad mindset. And if I'm really honest, I don't necessarily think younger girls have changed their mindset particularly. I think the midlife woman now is understanding and seeing, hopefully, that strength training is okay. But then that's if you're, an affluent woman using Instagram, understanding that you've got access to all of these resources. But you could be a woman who doesn't have access to these resources. And so we need to kind of normalize it. One of the things I really like to recommend, actually, I've got one with me, is I actually recommend weighted vests a lot, Emily. So I'm showing you my little weighted vest. It's just about 5 kilos.
I have one. You got me onto it.
So, just walking around wearing a weighted vest can be really helpful for strength training in women, especially at midlife. I think what I would say, though, is it's never too early to be thinking about your long-term health, and it's never too late. So there is no point where a woman's going to come to me and I'll say, it's too late for me to help you. It might be too late for me to prescribe you some of the HRT. I brought some with me today. It might be too late for me to give it to you.
We can quickly go through those before we wrap up.
So with regards to hormones, the way I sort of look at them is you've got what I would call true HRT. That's me giving you estrogen, the thing you need, progesterone to protect the lining of your womb. And then there's topical and local estrogens that are solving local problems. So the genital system gets really dry, sore, recurrent infections, bleeding, itching, painful sex, a whole host of symptoms. Putting estrogen into the vagina is incredibly effective, and it is not true HRT. So when you use vaginal estrogen, I brought a little pessary with me. This is just one example. This is just a little device that goes inside the vagina. And what you're ejecting is just a little tablet, which we call a pessary in the UK, that dissolves inside the vaginal cavity. And what this will do is it will really reinvigorate the tissues, make them more bouncy, more elastic, less painful, less sore, less infections. Putting one of those little pessaries in, the average dose, just so you know, is about 2 or 3 times a week. If you put one in every day for 1 year, the amount of estrogen in a woman's bloodstream will equal 1 oral HRT tablet for the whole year.
So it's tiny.
Is nothing. It's not even tiny. It's like nothing. So even women with breast cancer can use vaginal estrogen. And women are petrified of estrogen because of this study that was done. Women are still petrified. Doctors are still telling them not to use it, or just you go a bit longer, wait a bit longer. But we've got all this science saying, actually, we think you're going to live longer if you start estrogen earlier. Interestingly, there was a UK biobank study done recently. So the biobank is like a big database in the UK, lots of volunteers giving their health data. And they looked at associations around longevity, so living a longer life. And there's an association between being on estradiol and living longer. Now, is that because people who use HRT might be more affluent? Are those women more health seeking because they're more in tune? Are they eating better, living better, exercising? Is that why they live longer? Or is it because they're on estradiol? And we're trying to work that out.
And there's a big link between feeling better and making better choices. So if you don't have maybe the anxiety anymore, or maybe you're less fatigued, or your brain fog has cleared a bit, maybe then you're making better choices because you're feeling more positive. So you're going out to exercise, or perhaps you're sleeping better, because sleep is such a big thing for women in menopause.
When you're going through menopause, your sleep is really disrupted. There are many reasons why that happens, but if your sleep is disrupted, you're going to feel awful. So one of the first things I do when a woman comes and sees me is I'll just get the basics down. How are you sleeping? And you might have menopausal symptoms, and I might think they're estrogen deficiency symptoms, and I might think that I can help you. But if that woman is not sleeping, then nothing is going to get better. And sleep has a huge impact on anxiety, on how you eat, on whether you move, on how you relate with your loved ones around you, how you relate with your co-workers. So sleep is huge. One of the things we give in combined HRT is something called oral micronized progesterone. And this is a very closely matched progesterone to your natural progesterone. And interestingly, when you swallow it and it digests through the effects of something called GABA, it basically becomes a bit sedative, and it can be really helpful in improving a woman's sleep if she needs combined HRT. And, you know, I think we underestimate how much we need to prioritize sleep. And I think as a perimenopausal woman myself, I know that my sleep is disrupted now, and things like alcohol really disrupt it. I know that if I eat too much kind of, fun cakes and sweets and biscuits, I won't have as good a night's sleep than if I hadn't eaten that. If I have a glass of champagne or Prosecco or something with a friend, at dinner, then I'm making a choice the minute I drink that to have maybe a bit of a worse night's sleep at the moment. And at some point I might adapt to that, but many women don't really adapt to the changes that their body has around alcohol use. And alcohol's obviously not essential. So I think sleep is huge, and there's a lot of information out there. The basics are, dark, cool, quiet. You need your environment to be right. You need to not have blue light. You need to kind of be treating sleep as its own entity. I respect my sleep, and I'm going to respect the environment in which I'm going to sleep in. So if it's full of lots of distractions, and for many women that may not be a choice, but if it is, you're going to find sleep even more difficult. And the symptoms of menopause can disrupt sleep. And so that's where the option around hormone replacement therapy comes in. But like I said, what's important, I think, around HRT, whichever way you have it, is that actually you decide, why am I on it? Am I choosing it because I have symptoms and I want those symptoms to get better? And if hormones are not what you want, there are other things that we can do to help manage your symptoms. Cognitive behavioral therapy is hugely evidence for night sweats because there's an element of brain function having an effect on how you feel and how those physical symptoms come out. Again, nutrition, I can't say it enough. The foundations of everything we do is what we eat, how we move, how we sleep, and how we feel. And you need to be paying attention to all those aspects in your life and then saying, will hormones support this or not? But do I choose hormones for some of these other long-term health benefits that are associated with them? And I think women don't know about the heart health benefits, the bone health benefits, to some extent the cognitive benefits. Lisa Mosconi is this amazing neuroscientist in the States doing tons of research around women's brains health. And, they're doing neuroimaging studies. They're looking at menopausal brains. They're seeing the differences pre and post menopause. It's really exciting stuff. And I think what we do understand is that women who are using HRT, who are able to, may be wearing off are the problems that are down the road, because they're replacing the hormone. Remember, prevention is better than cure with estrogen. So what we're doing with the estrogen is we're using it as a preventative method. You know, many women will be on HRT as long as they're healthy and well until they die, or until I have a good, decent bit of scientific evidence saying, no, we should stop it. Because with regards to the long-term health benefits, we know that some of them max out. So if you're on HRT and I'm telling you it's going to help your heart health, remember, providing you're not trying hard to have a heart attack by smoking and doing other things, then we think that max benefits around a decade. Once you've been on it for a decade, we think you've absorbed all of the heart health benefits. And after that decade, you're probably not getting any extra benefit.
Yeah.
And that's when your prescriber should be saying, all right, let's rethink. Do you want to stay on it? Why might you want to stay on it? HRT, estrogen replacement, will always help your hot flushes if you get them. You know, it will always be strengthening your bones. It will always be helping your muscle function. It may always be doing something useful for your cognitive function. So these conversations, I think, don't happen enough. I think women are, you know, I think we're in a mess in the UK where either they're being given something that's not correct, they're being told it's too early, that's not true. They're being told you can have it, but you can only have it for a very short time. Not true. They're being given off the shelf, well, this is the only HRT I give here. There are so many options, and I don't necessarily think that everybody understands the nuances between one product compared to the next. We know a lot about the type of progesterone that women need to protect their womb and the risks that each different type of progestogen can have. So there are synthetic progestogens which carry more risks than the more natural micronized progesterones. Women don't understand the nuances between this. So I think women are getting HRT, but it's just like an off the shelf, this is all I give.
Yeah.
And if that doesn't suit them, then a woman believes, well, that means it's not for me. And they don't go back, and they don't realize there's many other options and conversations that can be had around what might be useful for them long term.
So this really is an important message, and it's trial and error. It's a bit like girls who go on the pill or try different forms of contraception. You might try the implant, doesn't work for you, so you try the pill. You might try 5 pills before you find one which makes you feel okay.
100%.
So this is a similar process, and I think it's good to realize that our hormones affect us in every way that we can imagine. It affects everything we do, choices we make, lifestyle, sleep, how we're feeling, our relationships. This is such a fundamental thing that if we can get right, could really, really form our whole life into a different pattern than if we weren't doing it. Unfortunately, we've run out of time. I'm sad, but I think we need to continue this discussion another time, because I know you have so much more to say on the menopause. At Dr. Reem, that's you on TikTok, isn't it? Women's Wellness Clinic on Instagram. You're doing obviously face-to-face consultations, but you're also are you doing online ones as well?
Yeah, so womenswellnessclinic.co.uk is our website and our business. Myself and Dr. Shields, another British Menopause Society specialist, offer face-to-face consultations and also online remote consultations. So we can help you wherever you are.
I could talk to you about this for hours. Love it. Thank you so much, Reem.
You're welcome.